Hello, welcome to the Center for Connected Health Policy's Medicaid and State Telehealth Policy webinar series, Summer Edition. My name is Nichole. I'm the Executive Director of the Center for Connected Health Policy, and our topic for today's webinar will be school-based telehealth. A few disclaimers and friendly reminders before we get started. Please note that any information provided in today's webinar is not to be considered legal advice. It is strictly for informational purposes. We always ask that you consult with your organization's legal counsel if you are interested in a formal legal opinion. Also know that neither CCHP nor any of our speakers have any relevant financial interest, arrangement, or affiliation with any organizations related to commercial products or services that may be discussed in this program. Today's webinar is being recorded and slides presented here will be made publicly accessible on our CCHP website. Closed captioning is also available, so you'll see on your toolbar for Zoom that there is a closed caption button that you can use. We ask that everyone please refrain from any types of political statements or advertising commercial products or services during the webinar. If you have questions for our panelists, we ask that you use the Q&A function. The chat function should only be used if you are having any types of technical difficulties. A bit of background about CCHP. We were established as a program underneath the Public Health Institute in 2009 to really be a California-based telehealth policy organization. However, an opportunity to become the federally designated National Telehealth Policy Resource Center became available in 2012 through a grant from HRSA. CCHP applied for that. We received it, and we've been serving in that capacity ever since. We also work with a variety of other funders and partners on the state and federal level. We also act as an administrator for the National Consortium of Telehealth Resource Centers, and we are a convener for a group in California called the California Telehealth Policy Coalition. A little bit of background information on the National Consortium of Telehealth Resource Centers. It is made up of the 14 telehealth resource centers who are underneath the same grant program as CCHP. There are 12 regional resource centers that cover specific states and territories, and there are 2 national centers, one on technology and one on policy, which is CCHP. Several years back, the 14 telehealth resource centers decided to combine a portion of their resources to do joint and collaborative works and form the National Consortium of TRCs. Note that this is the first of a 4-week series. We will have other topics, and each webinar will take place every Friday at the same time for the rest of June. For June 10th, the topic will be on licensure, June 17th, private payer laws, and June 24th, substance use disorders and telehealth. For today's webinar, we are fortunate to have a lineup of terrific speakers. First, we'll hear from Christie Guinn, named Governmental Affairs Committee Chair and Deputy Chief Bureau, Exempt Services and Program Bureau, Medical Assistant Division of the New Mexico Human Services Department. Nichole Small, Section Chief Policy Management and Development, and Meredith Schram, Health Systems Administrator for the Ohio Department of Medicaid, and Andrea Shore, Chief Program Officer for School-Based Health Alliance, and Melanie Wildlane, Executive Director for the Connecticut Association of School-Based Health Centers. Before we get started with our first speakers, just a little bit of level setting for some of the audience here who may not be familiar. When we talk about telehealth in the schools, we're really talking about 2 approaches that may be used or taken when telehealth is utilized. There is telehealth, which is being used to provide services that schools are required to provide. And then there may be a telehealth school-based program where they are engaging with perhaps a community provider to provide those services in a school setting. Our speakers will help clarify the differences and what are some of the existing policies that states may have in place. So I'll turn it over to our first speaker, who is Christie Guinn. Again, as I mentioned earlier, she is the Deputy Chief Bureau for New Mexico's Human Services Department, Medical Assistant Division, Exempt Services and Program Bureau. She holds a master's degree from New Mexico State University. She has worked at New Mexico Medicaid since October of 2012 and previously spent 6 years as a district level coordinator for the Medicaid School-Based Services Program at one of the top billing districts in the state. Her role includes oversight of the school-based Medicaid programs in Mexico, including the Medicaid School-Based Services Program. And Christie has guided the state through a state plan amendment and the transition to cost-based reimbursement, and is currently leading New Mexico in the implementation of billing for non-IEP services. She has also served as the named board of directors since November 2012. So I will now hand it over to Christie.
Thank you, May. Glad to be here today, and hopefully my voice holds out. My allergies have been terrible, so we'll try to get through this as best as we can. So as May said, Christie Guinn, work with New Mexico Medicaid, and then also representing the National Alliance for Medicaid and Education. So next slide, please. Want to give just a brief background about NAME, because I think it's a vital resource for people who are working in the school-based education and Medicaid realm. So the National Alliance for Medicaid and Education was established in 2003 and was created really in response to the need for some type of national forum to address complexities and challenges of school-based Medicaid reimbursement programs in school settings. So states were implementing and supporting school-based Medicaid programs without any type of real guidance from the federal level, and things were being done differently. And so numbers of states and representatives got together to form the organization, where we can draw on that expertise of those highly informed and specialized sources from around the country, as well as working with federal, state, and local government levels, and our partners from the private sector, including billers and IEP program vendors, and everyone who can potentially support school-based Medicaid programs. And so we really do serve as a clearinghouse for information and helping our members to be able to navigate these sometimes difficult waters with our access to professional networking and information sources from around the country. Next slide, please. So NAME's mission of championing collaboration, integrity, and school-based Medicaid, and our vision of envisioning the day when public policy promotes student learning and wellness as essential to learning are the two areas we really focus on in the work that we do with our members, our federal partners, and our strategic partners, who all have the same goal of enhancing school-based Medicaid programs. Next slide, please. So NAME members are a variety of individuals who come from the state, local, and even federal level, including program developers and administrators, our policymakers and implementers, educators, and the actual clinicians or providers who are working in the school setting. So our 300 members include representatives from state Medicaid agencies, state education agencies, local education agencies, professional organizations, and our billing consultants and companies. And there is also a listserv of over 2,000 friends of NAME as well. Next slide, please. We have a number of strategic partners that we work with in supporting our vision and mission, including the School Superintendents Association, Council for Administrators of Special Education, and the Healthy Schools Campaign, who both helped host a virtual webinar series that we did in 2020-21 in place of our annual conference, the National Association of Medicaid Directors, at the National Association of State Directors of Special Education, and the School-Based Health Alliance. Next slide, please. So I want to start by talking about what many states have been working on since 2014, which was the free care expansion. So most of us are aware that school-based Medicaid services in the school setting were typically billed as those services that were provided under an IEP or IFSP. So our special education students who would be receiving therapy services and would also be Medicaid enrolled, those school districts providing services would have the opportunity to submit and claim Medicaid reimbursement for those services. And so there had been what had been known as the free care policy, which basically said that if a school district was providing other services outside of an IEP free of care to the general student population, then those services were not eligible for Medicaid reimbursement. And so in December of 2014, the Centers for Medicare and Medicaid Services, our federal oversight agency, CMS, issued a letter announcing that there has been a shift in that policy that was going to allow states for more flexibility in their school-based Medicaid programs. So what this meant in layman's terms is that schools would now be eligible to seek reimbursement for all Medicaid covered services provided to any student in the school, as long as that student was enrolled in Medicaid, regardless of whether or not those services were provided at no cost to other students. So this was a huge shift in what had been federal policy leading up to that point, and it had been prohibiting districts from seeking additional Medicaid reimbursement. Next slide, please. So as of last month, there were 17 states who have successfully expanded their school-based Medicaid programs. The majority of them have had to do so through what's known as a state plan amendment. And there are currently more states, including mine, that are currently working to do so. And the Healthy Students Promising Futures Learning Collaborative, that's part of the Healthy Schools campaign, has a school Medicaid programs map that is accessible through the link in this presentation for you to go in and take a look at where each of the states are in the process. And so when we talk about state plan amendments, schools have had to wait for the state Medicaid agencies to move forward with formal approval of these documents with CMS to get their programs expanded to cover these additional non-IEP services. And so state Medicaid agencies will work in collaboration with the local LEAs, the state education department, potentially departments of health, to put together the framework for the billing for non-IEP services. And that all has to be reviewed and approved by CMS before the expansion can be implemented in a state. So states, of course, see this as an opportunity to bring additional resources to expand health services for our most vulnerable students. And we know that when students are spending the majority of their day in the school-based setting, it's a prime opportunity to be able to provide those services without the students having to leave school, without the parents having to take off work to then take the child to appointments. If services are accessible in the school-based setting, it's really a win-win for everyone. So school districts are really having to think about how to meet the increased demand, specifically for mental health services. And we know that that's something that's going to have a more significant focus as we come out of the pandemic. And the policymakers having to consider every option to be able to build capacity to support that need at both the state and the local levels. So for example, in New Mexico, we know that there is a shortage of behavioral health providers. We hear from our schools that as it is, they have a hard time sometimes finding providers to meet the needs for IEP services. So the fact that we have an option for billing for students, under regular ed that are receiving services is great, but that need can only be met if they have providers that are available to meet with those students. Next slide, please. So when we specifically talk about telehealth in relation to school-based services, pre-COVID, telehealth was something that I would say is not consistently used for both IEP and those non-IEP services. In many cases, we've heard from states across the country through surveys that NAME has done in collaboration with some of our partners, that unreliable broadband infrastructure and even just lack of equipment is something that has been a barrier. And so as we transitioned into the pandemic, just in terms of meeting the needs for IEP services, the school districts really had, in some cases, struggled to be able to get up to speed to provide telehealth for those federally required IEP services. And that might mean that they had to support families through providing hotspots. It might mean that they had to support families with sufficient equipment to be able to have those telehealth services, and sometimes a combination of both. The other concern around telehealth pre-COVID is that many states did not have approved Medicaid plans that included billing for services that were provided via telehealth. So the state Medicaid plan has to specifically list telehealth as an allowable model or delivery method for providing services. So in some cases, the schools were not listed as approved originating sites for the services to be provided. And in some cases, what are known as asynchronous or store and forward services are also not billable. So those services that are not being provided live time. So maybe a service where a therapist does a brief recording of a particular, for example, an occupational therapist might do a recording of a particular skill. They send that recording home to the family. The parent and the child watch that video. They may even send a video back to the therapist of the child, demonstrating their attempts at or competence of that activity. When those are not being provided in live time, in many cases, those services were not billable. And so this was something that was prohibiting billing, even if we were meeting the needs of the students. There may be cases where services were not billable. Next slide, please. So as we moved into the pandemic, states, of course, very quickly sought emergency approvals from CMS to allow the billing of services provided via telehealth. And so in some cases, those were ensuring schools were listed as appropriate sites. We also needed to provide guidance to the schools and the providers for which measures, would be in place and how they would appropriately bill for those services. And now the states must evaluate which of those emergency measures are going to potentially become permanent post-COVID. So one of the big things we've heard and we've seen across the country is that these were things that need to remain in place. Telehealth, now that it's been implemented and sometimes fully implemented in the school districts across our state, is not going away. And so the states need to evaluate how to make those emergency approvals part of the permanent plans so that billing for telehealth services can continue post-COVID. We've seen states use their COVID relief funds in a variety of ways, including enhancing those broadband services I talked about earlier, and being able to provide that telehealth equipment. So, a lot of the COVID relief funds, of course, have come out. Those are one-time funds. That's not something that's going to be, recurring funding from the federal government. So finding creative ways to utilize that money to set up that infrastructure so that the use of providing services through telehealth and billing Medicaid for those services can continue once those COVID relief funds are gone. I think another thing that was ultimately important, specifically related to our IEP services, is that the school districts needed to focus on providing those services, regardless of whether or not those services were going to be billable. So in New Mexico, another one of the things we did, we talked about the asynchronous services. We talked with our special education department within our Department of Education about services that may be provided in a manner that would not meet Medicaid billing rules, but should still count towards IEP time. So for example, some of the Medicaid codes we use in New Mexico are time limited. So there are rules around the length of time that a service has to occur for before it can become billable. So for example, if a behavioral health provider is checking in on a kid and they spend 5 minutes on the phone talking to that child, that is not going to meet the billing rules. It doesn't mean that it wasn't 5 minutes provided toward that child's IEP time. It just means that that's not something that's going to be eligible for submission as a Medicaid claim. So really ensuring that our providers understood, especially in the special education realm, that the focus should be on meeting IEP time, providing those services. If we're talking about the very beginning of COVID, schools were doing paper packets. They were sending things home to parents, and those things were being sent back to the school without any real live face-to-face time for some of the billable services as we would traditionally see. Another thing we've talked about specifically related to IEP services is the parental consent that is required by IDEA that has to be obtained before a district can bill Medicaid for a child's services. So if you have a child who came in new to special education during the middle of the pandemic, the school district is required to obtain that parental consent prior to billing Medicaid for those services. And that was increasingly difficult to obtain during periods of remote learning where our IEPs were being held virtually. And, forms would have to be sent home. Parents may or may not return them. Very different methodology from what is done when we're in a true in-person world all of the time. The parent attends the IEP meeting in person, that consent form can be signed. So really having to navigate those issues was potentially difficult for some of the schools, and really having to shift their methodologies to include ways to obtain these consents electronically. Next slide, please. So some of the work that NAME and our other strategic partners, including the Healthy Schools Campaign and the School-Based Health Alliance, have been involved in is really engaging the federal agencies, so the United States Department of Education, both Office of Special Education Programs and Office of Special Education Rehabilitative Services, to discuss that parental consent requirement, and really educating them about the burden that that requirement places on schools. And quite frankly, that it's also a duplication of the existing Medicaid consents that are done when someone enrolls in Medicaid benefits. When you are enrolling and accepting Medicaid benefits, you are agreeing to have any Medicaid providers seek reimbursement for those services at that time. And we've been really engaged, especially over I would say the last 6 to 8 months, in some very in-depth conversations with them about this. And we're really hopeful that we're going to see some movement on this, and that they're really, coming to understand the difficulties that this has placed on the schools, the barrier that has been for schools seeking Medicaid reimbursement, and the need to make some changes to that to be able to maximize the amount of federal Medicaid dollars that schools can draw down for these related services. Another big area that we have focused on has been conversations with CMS on providing updated guidance for our school-based Medicaid program, and specifically including free care services in that. So those of you who are familiar with Medicaid in the school-based setting know that the last guidance that CMS put forward around school-based Medicaid was back in 2003. And a lot has changed since then. And so there's been discussion for several years, I would say going back as far as 2015, with CMS about the need to update this guidance, provide consistent guidance, because lots of things have been said by CMS about policy that isn't written anywhere. So really needing to get consistent, updated guidance and ensure that this new free care piece for non-IEP services is included in all of that, because states, and I think that's really one of the reasons states have been slow to take up this billing for non-IEP services, is that there has not been anything clearly put out from the federal level. So states are having to write state plan amendments, implementation plans for their time studies, and really navigate this on a case-by-case basis. So really encouraging and advocating for that updated guidance at the federal level, to ensure that these programs can be consistently implemented. And I think the last important piece of that is that the federal and state policymakers ensure that the schools continue to have not only the support, but the guidance and resources that they need to deliver services through telehealth, and that these pandemic-era policies will continue to support telehealth beyond the pandemic. Next slide, please. So I think another thing that's really important for states to realize is that there has to be interaction between our state agencies. So we know that the school-based Medicaid programs are administered in a variety of ways across the country. And even just within my own state, I know that that is true. So it's really essential that there is good collaboration and coordination between the state Medicaid and the state education agencies to ensure success of this program. So the state Medicaid agency, of course, is going to house the state plan amendments, the implementation plans, and the regulatory documents between the state Medicaid and the federal Medicaid agency. But in some cases, the state education agency is deeply involved in the actual implementation and training and coordination with the LEAs. And I've had some conversations recently that were kind of interesting in terms of the requirement that's specifically related to our IEP services. There's a requirement in 34 CFR 300 section 142 that an interagency agreement exists between the state Medicaid and the state education agency. And that's basically to allow the billing piece for those IEP related services. But it's also an opportunity for the agencies to include additional language around those non-IEP services and the interagency collaboration to support schools. So for example, in New Mexico, our interagency agreement discusses responsibilities for both my agency as the Medicaid agency and our public education department, and how we are going to collaborate when it comes to training and communication with the schools, how we assist each other in data sharing that might need to happen between the agencies in terms of validating our eligibility rates, in terms of ensuring that we are both working together to reduce administrative burden for the schools and streamline processes where we can. And our interagency agreement actually includes a funding piece where we pay a portion of the salary for that staff member at the education department. So not only is there an agreement, there's a funding commitment there, which ensures that we have a contact that not only my Medicaid staff, but also our schools can reach out to when they're having issues. So even something like licensure, if an ancillary provider is seeking licensure through our education department and they're having issues, they know that there's a contact that they can go to seek some support. If they're having questions or concerns about school health policy that may not specifically be Medicaid related, but related to how health plans should be developed and implemented in the school setting, that individual is a contact that can serve as a resource for them. It also guarantees that we have a contract with our special education department and the collaboration that is needed specifically for our IEP related services. So in terms of things like suggested changes to our IEP template, we have the ability to reach out to them and work collaboratively to ensure that all of the pieces that need to be in place to ensure successful Medicaid billing can occur and that the schools are going to get consistent guidance from both departments. So I think that's another really key piece that states need to be thinking about and need to be considering. Next slide, please. So I'm going to give two more quick plugs for NAME if anyone is interested in joining. We have membership dues. It's set at just a reasonable $50 a year. There's the link to the website, or people can register to attend our annual conference, and that registration would include the dues for the remainder of the current year and the next calendar year. Next slide. Our 20th annual conference is going to be held this October in Baltimore, Maryland. So as I said, registration would include membership for the rest of 22 and 2023. And there is a link to the NAME website and the event page, but there's also a lot of resources available on our webpage. Resources around free care, resources around the parental consent piece, things that we have done in collaboration with surveys. So some of it is linked only to the members only page, but there are other things that are accessed on the public side of the page as well. Next slide. So with that, there is my contact information. I'm always happy to answer questions. Phone number is there. And then I know we will provide my email as well at the end of the presentation. So happy to entertain the questions at this point.
Thank you, Christie, for a great presentation, and also for that wonderful level setting on like not only around telehealth, but just policy in general, both on how the federal and state policies sort of interact with each other. I have a question for you for something that you said that I thought was really interesting, and it's the interagency agreements. I have actually said to many people in the past of like trying to coordinate different departments in a state, and with like the Medicaid telehealth policies, are there interagency agreements that perhaps you can utilize to help facilitate that communication? Now, New Mexico is really interesting in that you help essentially co-fund with Department of Education a liaison. So that person is like aware of what's going on in Medicaid, but also Department of Ed. Is that common, do you know, for other states, or are you guys a unique sort of like, you know, creature in like doing that and having that common person that you each sort of contribute funding towards?
To my knowledge, it is New Mexico, and I believe the state of Louisiana that actually has the funding mechanism embedded in that policy. So, you know, many states may have the agreements, there may be staff, but there is not necessarily the funding link that is established to support that, which, I mean, I really do believe that it makes it a much stronger relationship, because if we're paying a part of that person's salary, we have, you know, claim to be able to utilize them for the portion of time that we're paid for. So I think that is a really unique thing, but definitely something that, you know, and I'm happy to share the language of our agreement and how that is done as well.
No, I definitely agree with you in that that is important to have that common staff person, that investment in that person from both departments. So if we get a lot of state folks on these webinars, if you are interested in that model, New Mexico, you may want to like take a look at and contact Christie further, or you can contact CCHP and we can try to facilitate that. I'm going to take only one question from the Q&A to give your voice a rest there, Christie, but it is from Socrates, and I apologize ahead of time if I butcher anybody's names. Socrates Agayo. If students are covered by a Medicaid managed care organization, would the school need to bill the MCO, or could they bill the state directly?
Good question. So most states, even if their regular Medicaid program functions under a managed care model, the school-based programs are typically what's known as carved out. Tennessee is one exception. So Tennessee's program is 100% managed care. But the majority of school-based programs are carved out of managed care. So what that means is the school districts do not enroll with the managed care organizations as providers. It's known as what's a fee-for-service program. So, and even if they are functioning under a cost settlement methodology, the claims are submitted directly, and a lot of times through a third-party biller, but the claims are submitted directly to the state Medicaid program's fiscal agent and processed directly through state Medicaid. So it simplifies things because they're not having to bill through what are potentially multiple managed care organizations in the state. And so that's the typical model for, I would say, for school-based IEP, and now this expansion under the non-IEP services.
All right. Thank you for that question, Socrates. Thank you, Christie. Christie will be back towards the end of the webinar. We're going to let her go ahead and give her voice a rest there, and we'll move on to our next speakers. So just give me 1 second here as I pull up their slides and get them ready here. We are going to hear next from Ohio Medicaid. We have with us today Nichole Small, who serves as Section Chief and Policy Management and Development of Ohio Department of Medicaid. As a health plan policy administrator, Nichole develops and implements statewide telehealth policy covering approximately 3 million Ohioans and a large network of active providers. She is responsible for various Ohio Medicaid policies related to reimbursement, alternative payment models, and coordination of benefits. She participates in the standards maintenance and development for electronic data inter-exchange transactions maintained by the Accredited Standards Committee X12 and serves as secretary for the technical work groups responsible for addressing requests for interpretation. She holds a master's of business administration and healthcare management from Ohio Christian University and has more than a decade experience in healthcare industry. We are also going to be joined by Meredith Schram, who is the health system administrator in the Bureau of Health Plan Policy at the Ohio Department of Medicaid. Meredith joined the agency in December of 2021 and is responsible for developing telehealth policy serving nearly 3 million Ohioans. She is currently leading telehealth policy update efforts to ensure appropriate provisions are accessible to members following the public health emergency. She also evaluates and assesses program needs related to other general provisions, including reimbursement, claim submissions, and alternative payment models, ensuring all policies comply with federal and state regulations, rules, and laws. Meredith acts as a policy liaison, collaborating with other groups within ODM, sister agencies, and external stakeholder groups. She holds a master's of health administration from the Ohio State University and completed her administrative fellowship in the University Hospitals Health System in Cleveland, Ohio. So I will now turn it over to Nichole and Meredith.
Thank you, May. Hi, everyone. I'm Nichole Small. Along with Meredith, we're at the Department of Medicaid in Ohio. We are in our Bureau of Health Plan Policy. So like May said, we do a lot of different things, provider requirements, general policies, and of course, telehealth. Next slide, please. So just to kind of level set, just to give kind of a couple differences between the virtual school-based health, how you can have telehealth in 2 different settings. So we have the Medicaid school program, which of course is restricted to children with the IEP. And then we have virtual school-based health, which would just be available to anyone, not just those with an IEP. So it might be a provider who partners with the school or is, located in the proximity of the school campus. So just as far as the fee schedule, for MSP, it's more limited. It's restricted to those children with an IEP. So only certain services are covered, like PT, OT, speech language. As far as the, wider bucket of school-based health, we have that would follow our normal telehealth rule, which covers quite a few more services and practitioner types that most providers outside of the MSP specific provider type that we have would utilize. So for MSP, it's a specific provider type in our system, but for the broader school-based health, it could be any telehealth provider. Usually we have professional medical groups, outpatient clinics, Fqhcs, rural health clinics. So those can be enrolled as Medicaid providers, and they're eligible to provide telehealth services. So for MSP, it's restricted to, only the services that are identified on the IEP can be provided. So they have to be written in that plan. In the broader sense of school-based telehealth, any medically necessary services can be provided. In MSP, the school district pays the state share. Christie kind of touched on this, and then we submit it for the federal share. And there are cost reports, involved in the MSP program. So for the kind of broader school-based health, claims would just be submitted like a typical visit. It's just a typical provider. They would, there's some additional billing requirements as far as modifiers and things like that, that would still be used in both cases. But in the case of the broader school-based health, we would pay the state share and submit to CMS for the federal share. So for MSP, we work closely with the Department of Education here in Ohio. So we have a liaison at the Department of Medicaid and then one with ODE to jointly implement this program. And then for the broader school-based health, we do work with the schools and the Department of Education as needed to inform kind of our general telehealth policy. So I just wanted to provide that kind of high level before we kind of talk about the two in a little more detail. So next slide, please. So here we'll just provide a little more information about the Ohio Medicaid School Program. So this was established for local education agencies to receive the federal matching funds for Medicaid. So the services must be medically necessary, just like any other Medicaid service. The practitioners have to have a Medicaid agreement, practicing within their scope of practice. So pretty typical requirements here. And then we provided a link to the Medicaid school program, our administrative code rules that will give you more specific details. But this is where, like I said, it's MSP covers the services that are identified in the individualized education program, whereas the school-based health could be non-IEP services provided really to anyone that is eligible for Medicaid. So like I said, the MSP provider type is 28 in our system, and then the program year follows the state fiscal year, July 1st through June 30th. Next slide, please. So here we just have, the requirements for providers, provided the revised code sections for the different requirements that schools have to meet in order to implement, the Medicaid school program. So there are quite a few regulations that have to be adhered to, and then they have the provider agreement, which is our standard provider agreement, but they're just assigned a different provider type in our system. So the schools can contract or employ the providers that are eligible for telehealth in our normal broader telehealth policy. So there's kind of some overlap there. Any practitioner that's enrolled is subject to background checks and have to apply for a provider agreement. So as far as claim submission, there are claim requirements for the Medicaid school program in our administrative code rules. So we provided those here if you want to take a look at those. But really it comes over just like it looks like a normal claim, but it's the school is still doing a cost report, and the school district generally pays the state share. So we're just claiming for that federal share. And then there's the cost report and cost reconciliation. So again, we provided the link here for the administrative code rule that we have that governs that process. And in Ohio, we do have the MSP program is carved out of managed care. So all of these claims would be submitted through fee-for-service. Next slide, please. So here's just kind of a workflow of how the process would go if you're a Medicaid school program provider. So you enroll just like you would a normal provider, but where you get a specific provider type, and then you deliver services that are identified in those IEPs. There's a random moment time study that has to occur. So those requirements are in our administrative code rule and 5160-35-02. And then there's the cost reports that have to be completed every year, and then the reconciliation. So that happens every year for the reconciliation, and the cost reports happen every year. Next slide, please. And so as far as the services that are reimbursable under the Medicaid school program, you have direct services like the physical therapy, occupational therapy, nursing, behavioral health services. We have targeted case management, two other buckets of, the services. We have the administrative activities and then transportation. So those are all covered under our Medicaid school program as a whole. So I'll hand it over to Meredith. She's going to talk about our general telehealth policy as it applies to kind of school-based health as a general program.
Yes, hello everyone. I'm Meredith. I work in our policy management and development section at ODM. And like Nichole said, I'm going to talk a little bit about our telehealth policy and show some data, talk about our pilot program that we've got going on and what's next. So first, our vision and goals for our telehealth policy. We certainly don't intend for telehealth necessarily to ever completely replace in-person care. So we want to make sure the care that's provided is clinically appropriate to be provided virtually, also while maintaining that fiscal sustainability and integrity of the program. So we want to make sure that we are maintaining that quality of care and enhancing access for patients, bridging the gap between visits, perhaps, improving health outcomes, and providing flexibility for providers and patients. Next slide, please. This slide is just a little high-level overview of our Chapter 1 rule. So currently, patients can access telehealth in most places. Certainly throughout the pandemic, the home was the biggest bucket where patients received care, and school was the second bucket. There's a wide range of services that we allow in Ohio. We certainly expanded through the PHE and are continuously looking at what we need to be adding or maybe removing in the future. Communication can be synchronous or asynchronous, so that's real-time interaction. We also allow audio only, remote patient monitoring, and secure patient portal communication. It's important to note that our telehealth services are paid the same rate as if they were provided in person. And also our clinical team, as well as Nichole and I, feel very strongly that it's important for anyone that's being seen virtually for at least 12 consecutive months, be seen at least once in person. There's a lot that you can miss, a lot of nonverbal communication. You can totally miss that somebody maybe gained 50 pounds in a year when you're just talking to them over the phone. So it's really important that that there's at least one in-person contact, especially for that shared decision-making process that we think is critical. Any procedure codes that are on our MSP fee schedule, which we've provided a link later in this presentation, but anything that's on that fee schedule that's also on our telehealth fee schedule can be provided virtually. And then both MSP and school-based, like non-MSP providers, follow our Chapter 1 rule. Next slide, please. So as I mentioned, we've expanded quite a bit, honestly, for eligible provider types during the pandemic. So initially we kind of just had physicians, podiatrists, psychiatrists, et cetera, and we added quite a few here in this middle column. And then, as I also mentioned, we're always looking at our rule. We'll probably open it again later this year to consider what all went down during the PHE. Next slide, please. Similarly, here's our eligible services, same concept, table-wise, really just had E&M and behavioral health diagnostics initially. We added quite a few services, and actually exciting to note that we added pregnancy education and diabetes management that will be effective later this summer. Next slide, please. Just a little data here. These are from our partners, Ohio Healthy Students profiles. You can see the majority of Ohio students enrolled in Medicaid have some sort of mental health, behavioral health condition that they need addressed. So definitely important when we think about our policy moving forward to consider the specific conditions impacting our students. Next slide. Silver lining certainly of the pandemic is data visualizations and data analytics were, I mean, just incredible what's been put together since the pandemic started. These two graphs you see here come straight out of our internal dashboard at ODM. They show on the left the total MSP claims, which peaked at 40,000 claims in January of 2021. And then on the right, you can see unique recipients that had a modifier with the patient location at school. We certainly want to note that modifiers weren't necessarily required at all times of the pandemic, especially in the early days. So we definitely think these numbers are a lot higher. Next slide, please. And moving forward to our really exciting school health pilot project. Next slide, please. Switzerland of Ohio, very interesting school district. It covers 3 counties and spans across 536 square miles. And there's actually 2,000 students that go to school in that district, which is great. But ODM proposed a $15 million investment in telehealth services to help bring some of these behavioral health services to schools. And this project was one of the 15 million investment that will be spread across the biennium. So it started in March of 2020, and it's been connecting students to behavioral health providers. If you go to the next slide. Some of the program goals were to extend access and increase continuity of care. Certainly, families didn't want to take their children into the doctor's office. They might cancel their appointment, but it's really important that if they need to be seen, they're seen as needed. Also, I mentioned the 500 square miles. It's quite a bit of driving, so we wanted to try to reduce that both patient and provider travel burden. I know it's been mentioned in today's webinar, there's certainly behavioral health shortages, provider shortages. So hopefully by bringing this program to that area of the state, more providers can see more students. And certainly we want to focus on chronic disease management and improve wellness, making sure that we're addressing any of these conditions that our students are living with. Increasing patient and really provider satisfaction too. Being able to see care more regularly is certainly important. And then as with the pandemic, you're not going to the doctor's office. That reduces some of that infectious disease spread. Next slide. So phase 1 was operational in February of 2021. We partnered with the Ohio State University Wexner Medical Center to get the infrastructure rolling. We saw 90% show rate, which is fantastic. 103 telehealth appointments were completed. As we saw in the first little data slide, there was depression and anxiety are actually the most common diagnosis for these children. But crisis intervention appeared to be successful in phase 1, which is great news. Phase 2 is ongoing, and we're currently working on connecting the school's existing fiber optic network to some of the more remote behavioral health professionals so that we can increase that access. And then lastly on the slide, our Innovate Ohio partners have put together a really awesome telehealth in schools blueprint. And we go to the next slide. We just give a high level checklist for things to consider if anyone of you all on the call today are interested in starting a telehealth program in your district. So of course, conducting a needs assessment, how many children in your school are on Medicaid, need services. What's the driving distance between, local providers and your students? Are there any providers in the area, a local college, a local university, another healthcare partner? What's your capacity look like? Do you have some, staffing issues as it is, and you can't really take on another big project similar to that readiness for change? What's your budget look like? Can you get this project rolling? Access to high-speed internet, that broadband is critical. If you don't have broadband, it's really hard to do anything, obviously, through video. So important to assess what your access looks like and what you might need to invest in. Space needs wise, certainly growing school districts. I understand that every classroom might be full, but it's really important that there's a private room that these telehealth visits can occur in. So making sure you've got enough space. Probably one of the more important items to know is to make sure you have IT support. If something goes wrong, nothing worse than being in your appointment and you can't connect. So very important there. And then finally, designing an operational workflow, who's doing what, when, and where. Next slide, please. Next slide. We've just shown the modifiers that are required, the GT modifier, place of service code, and patient location modifiers listed here just for reference. And then the next slide, we show, this is just an example. So say there's a 60-minute psychotherapy service provided via telehealth by a social worker to a student experiencing depression. During the session, certain factors increase the complexity of the treatment rendered, and the patient is physically located in the school, and the rendering practitioner is in their own home. Go to the next slide. So 60 minutes of psychotherapy, you would bill for $908.37 with a GT modifier. And because things got a little more complicated in the visit, you'd also add the $907.85, again with the GT modifier, the place of service code, and the patient location there as well. Next slide, please. So what's next for telehealth in schools? Go to the next slide. So we're looking at potential state plan amendments, perhaps even removing telehealth language from our state plan. We're looking at, hopefully the Switzerland project continues to be really successful and thinking about where we might expand within that district and beyond. And then lastly, that broadband access, really awesome to learn. March of this year, our Lieutenant Governor announced an awesome new tool to see where broadband is around the state of Ohio, so we can better pinpoint where we maybe need to be supporting other programs throughout the state. Next slide, please. And just some additional information and links. We've got our coordination of benefits rule here. If you're interested, need to know more. And then next slide. As promised, the Medicaid school program fee schedule link, and then links to our other telehealth related rule filings and other resources like billing guidelines and such. Next slide. And with that, we can take, Nichole and I can take any questions you might have.
Thank you, Nichole and Meredith. Great presentation there. You're doing a lot of work in Ohio. You've got quite a few questions in the Q&A, so we'll get right into it. Again, I apologize if I butcher your name, Afsana Kashishan. My apologies there. I know I did that wrong. What services can be billed asynchronously?
So we have, like, in the broader school-based, like the broader telehealth policy, there are some, I think, remote codes in there. So there's like some virtual visit codes, some other codes, if it's appropriate, you could potentially do it asynchronously, as long as it's appropriate with the code description. But we do have in our, if you look in our telehealth billing guidelines, there are some procedure codes that are specific to asynchronous.
Quite a few questions here about behavioral health. There's one from Anita Browning. Is your school-based telehealth in Ohio open to new behavioral health practitioners?
I'm not sure entirely how to answer that, but we do have quite a few. We have a range of different behavioral health practitioners that we enroll. I don't know if they're talking about like brand new types of practitioners, but we do enroll, licensed independent social workers. We have chemical dependency counselors, professional clinical counselors. So there's quite an array of practitioners that can provide behavioral health services.
We'll take one more question because we do still have two more speakers. I know everybody is eager to ask more questions, but both Nichole and Meredith will be back towards the end for our full panel discussion and Q&A. There's a question from Molly Snowden. How is the district handling established clients leaving the state of Ohio for summer and continuation of telemental health since no counseling compact is in place yet?
Well, we do have, I know we heard from the schools as far as telehealth, it really enabled them to connect with their kids, over the summer break so that there wasn't any gap in their progress that they're making in their behavioral health treatment or skilled therapy treatment like occupational therapy. So we know that that's been happening. I know there's some legislation that's been proposed in Ohio for a counseling, I think consortium or something like that, but I'm not entirely familiar with that.
All right, I know there's a lot more questions. As I said, both Nichole and Meredith will be back later, but we're going to move on to our next speakers here. So let me just pull up their PowerPoint very quickly as they turn their cameras on. Our next speakers, we have Andrea Shore, who is Chief Program Officer for the School-Based Health Alliance. She has worked in the public health field since 1997, leading child and adolescent health and youth development programs, many of which focus on the intersection of health and education. Her professional experience spans the local and national levels, including leading teams in designing, implementing, and improving health programs for children and youth. Andrea joined SBHA in 2015, where she serves on the executive team developing and implementing strategy and new partnerships, leads the organization's programmatic work, and serves as a school-based health center telehealth content liaison to the field. She has a bachelor's in arts and child development from Tufts University and a master of public health from Emory University. After Andrea, Melanie Wild-Lane will speak, and she is the executive director of the Connecticut Association of School-Based Health Centers. She has worked with the school-based center field for over 25 years, developing, implementing, and leading more than 25 school-based health centers throughout Connecticut. Before becoming CASBHC's executive director, Melanie served on the board of directors for many years, chairing CASBHC's annual conference and serving as the board's vice president. Now the executive director of CASBHC, the mission of the association is to develop opportunities for networking, continuing education, and advocacy to ensure every child in the state has access to affordable, high-quality health care. Melanie is working to lead the school-based health center teams around the state and implementing quality improvement and best practice measures while working to integrate school-based health centers into larger healthcare networks. I hand it over now to Andrea and Melanie.
Thank you, May. We gave you a lot to read. So we're excited to be here today. As May mentioned, I'm representing the School-Based Health Alliance, a national organization, and Melanie leads one of our affiliates. And so we're really going to share with you I'm going to share with you some specific programmatic information about school-based telehealth programs across the country being operated by school-based health centers. And they cover the types of work that our colleagues, the former presenters, talked about that are not traditionally covering IEP services. What the Free Care Act is now Free Care Rule is now allowing to be reimbursed, those types of services by an external provider. So we can go to the next slide, please. And I did just drop in the chat box a school-based telehealth resource playbook that we developed over the past year that some of the content from today I'll be sharing from. So I'm with the School-Based Health Alliance, and we are based in DC, and we believe that all children and adolescents deserve to thrive, but too many struggle because they lack equitable access to healthcare services. And just like Christie said at the very beginning, school-based healthcare is the place that makes natural sense to deliver care to students where they are all day. And our foci include policy, standards, data, and training to support and grow the school-based healthcare field, particularly school-based health centers. Next slide, please. So just a quick level setting here. This is how we show the types of school-based health services that you've heard everybody talking about today at the intersection of health and education, some of the traditional services that schools are required to cover. And then we also consider part of school-based health services, that bottom bullet, what we call school-based health care, including school-based health centers. Okay, next slide, please. So why school-based healthcare? School-based healthcare is when a community provider, like an external community health center, an Fqhc, a local hospital, a local medical center, partners with the schools to deliver care on site at the school. And that can be delivered in person or via telehealth. So we know as across the country that lots of schools either have shortages or don't even have a school nurse or school mental health providers. And so by partnering with these community-based organizations, schools can enhance even more the care that's offered to students at the school, who then come in and partner with any current and existing school-based health providers like a school nurse, school counselor, school social worker, et cetera. Sometimes in school-based healthcare is a few services that the external entity provides, like a vaccine clinic or behavioral health, but then sometimes they'll come in and provide a comprehensive medical behavioral healthcare model, and we call this a school-based health center. Okay, next slide, please. So we define a school-based health center as a shared commitment between a school and community healthcare organization that supports students and families in their health, well-being, and academic success by providing preventive, early intervention, and treatment services for schools. The community provider offers primary medical care and then very often behavioral health, as I mentioned, sometimes oral health, vision care. It can be a variety of services. Typically, the healthcare organization that comes in is a federally qualified health center, a hospital system, could be a county health department, and academic medical centers. Okay, next page, please. So you see here, we capture at the School-Based Health Alliance the types of school-based health center delivery models across the country, and we define them based on the first two items in the first column: the location of where the student accesses care, and in excuse me, and in most of these examples, it's at the school, or in the mobile example, they are in the mobile van right on the school campus. And then we also define it by where the location of where the provider delivers care. So in a traditional school-based health center, school linked, which is nearby a school campus, or a mobile van, in all of those instances, the provider could deliver care in person on site or remotely via telehealth, like we're talking about today. And then we have about 11% at our last census that we're delivering telehealth exclusive care, where all of the care to the students is being delivered via telehealth. And just to give you a little history here, you can see that the growth of school-based health centers has been steady and significant, with more than double the number of them in 2016-17 as compared to 1998. Okay. So we wrote this playbook that I shared in the chat room about a year ago. We were already exploring what was happening with the school-based health center field in telehealth. And as you can imagine, during COVID, that exploded. And we collaborated with the Mid-Atlantic Telehealth Resource Center and the Medical University of South Carolina's Center for Telehealth, Center of Excellence for Telehealth, to develop a telehealth program playbook to guide healthcare organizations through the design, implementation, and operation of a school-based telehealth program. So this playbook includes essential components for school-based telehealth startup, key considerations from healthcare entities across the country, and we have amendable resources in there for every stage of planning. Some of what we were just heard about before: needs assessment, consent forms, business agreements. Samples of those you can find in this playbook to see what healthcare entities are doing across the country if you are interested in starting up or enhancing your telehealth services in schools. Okay. So throughout this playbook, we talk about the distant site, of course, where the telehealth provider is delivering care, and then the originating site is where the student is throughout the definitions, and that is most often school. Of course, sometimes, as we had during COVID, that could be at home, but we are pretty much referring to that being school in this playbook. So in each of what we did was try to define the types of buckets of school-based telehealth programs we were seeing and hearing from across the country. And in all of these, the healthcare organization who's providing the care develops business agreements outlining their scopes of services and responsible parties and bi-directional communication practices with the school. Care coordination to ensure that students access some in-person care when necessary. Just like we heard in Ohio, we believe it's very important that all of that care is coordinated, because we know not every type of care can be delivered via telehealth. So we want to make sure those relationships are happening if the healthcare entity is not the entity delivering the in-person care. Sometimes we see these programs coming in and doing some rotating virtual in-person care. So I'll talk about that a little bit next. Next slide, please. So we define the first type of program in this playbook is where we have a comprehensive school-based health center plus hybrid telehealth model. So in this instance, a healthcare entity, maybe it's an Fqhc, comes in, operates a school-based health center at a school where all the primary care, medical care that I was saying is happening at the school or on a school campus. Students can access the in-person care there and get comprehensive care on site. But then students at the school-based health center who are enrolled in it can also receive some specialty care services via telehealth from a distant site. Okay, that's our first example. Next slide, please. The second bucket we found was still operating this comprehensive school-based health center at a school using telehealth network model. So in this instance, we've got the school-based health center happening on site at the school with that in-person comprehensive care. And then to expand services, the providers from the school-based health center can deliver care via telehealth to students at other satellite sites. So a school district might have a business agreement with this healthcare entity where some of the care is happening at the traditional school-based health center, but then they're also delivering some care via telehealth to students in their at other school sites in their school district. Next slide, please. Next, we have a telehealth network and rotating on-site services model. In this model, the healthcare organization does not operate a traditional school-based health center. Instead, they provide telehealth care to one or more schools, and then the telehealth program visits are assigned in providers' clinic schedules. The provider also regularly rotates through schools delivering some in-person care. So they're not always there in person, but they're rotating around delivering some in-person preventive care. When a provider is on site at a school, particularly if they're in a rural area and availability allows in their schedule, they might be delivering some in-person care at one school and then also getting slotted into their schedule some telehealth visits to other participating schools. So it can be really complex network business agreement happening here. Okay, and then our last model is the telehealth exclusive model. And of course, as the name says here, students are accessing their care at school and all of the care is delivered via telehealth. And again, those business agreements with the primary care providers and other care coordination efforts are really important here. So the telehealth providers are knowing what in-person preventive services are happening. So it's all part of a group effort to be working with these students. Okay, next slide, please. Within the playbook, I'm not going to dive into the details here, but we do get into business models, examples from across the country, and some great content about the different ways that these school-based telehealth programs are reimbursed and funded. So as you heard about today, a lot of that is happening through Medicaid and other billing opportunities. These programs definitely rely on some grants and giving, some fee for service, some managed care, and then some value-based payment models. So if you want some more details, you can dive into the playbook. But just so you know, there is a mixed model of funding sources of revenue for these school-based telehealth programs. And then lastly, we get into some details in the playbook too about some Medicaid considerations for school-based health centers. A lot of those were covered by colleagues today. So I'm not going to dive too deep into any of those. But I think the biggest piece here as a takeaway is that as some colleagues mentioned, that a school might not be designated as a facility site. So sometimes the healthcare entity needs to establish the school site as an official satellite clinic to bill as a originating site and the facility fees. So that needs to be determined about whether schools in your Medicaid plan are allowed to be considered the facility fee reimbursement. So we dive into more details throughout, but just wanted to share a little overview of that, and we're happy to reach out and respond with any more detailed questions as you take a look at that or answer some questions today. So I'll pass to Melanie so she can share with you what's happening with school-based health centers in Connecticut and telehealth.
Hi, thank you for having me today. You can go ahead to the next slide. So I'm going to tell you a little bit about school-based health centers in Connecticut, and then I'm going to talk a little bit about our advocacy work around telehealth in the state. Connecticut had a really big year for school-based health centers and for telehealth. So we have school-based health centers in 29 of our communities, and 25 of those communities have partial Department of Public Health funding. I would say we have over 200 school-based health centers. School-based health centers, like Andrea said, fall under two categories. School-based health center that's fully comprehensive. Those school-based health centers provide medical and behavioral health services, as well as they can provide dental health services. And then expanded school health services, which are single service only sites. And so we have well over 200, and we're trying to weed out the details currently right now to figure out who's doing what and where and what all their hours of operations are. So it's a big undertaking. You can go ahead to the next slide. You can go all the way down. There's 4 facts. So some basic facts about Connecticut school-based health centers that we've been around for 38 years, believe it or not. And pre-pandemic, we provided services to about 44,000 students each year, and in our fully licensed primary care facilities. Now, I want to be clear that we are not primary care providers. We do not replace primary care providers, but we do provide primary care services. So well child visits, vaccinations, things like that. As well as mental health services. And we bill for both Medicaid and commercial insurances whenever possible, wherever possible, for whatever service is possible. You can go ahead to the next slide. So this is no new news to anybody, but COVID closed our schools, and we saw a huge increase in the mental health needs of our students, youth and adolescents here in Connecticut, like every state did throughout the country. Our response in school-based health was to put in telehealth services. I will say that it did come with some significant challenges. It was not an easy task for us. Many of our parent organizations had been using telehealth services for a few years, but it was new to us because we did the face-to-face. Our patient pool and population was right there almost every day. And so we didn't need it. The only time we would have used telehealth services would be for a consult, and those were far and few between using telehealth. And for things like psychiatric services or med management when a parent couldn't be in the room with us. Next slide. So before I get into the challenges, I'll tell you a little bit about this graph. So here in Connecticut, Department of Public Health breaks the year into 3 periods. It's like a hockey game. And so as you can see in 2019-20, in the 3rd period, which was the onset of COVID, that's March to June, we saw a significant rise in the number of telehealth visits that we had. We were still trying to get a hold of what was going on, couldn't quite figure it out. Period 1 of 2021, that's July to October, it's a short period. Our visit numbers tanked. We weren't seeing anybody. It was, it definitely, we were trying to get a hold of what was happening in the schools. We were in a hybrid model. Everybody was in flux and trying to figure it out, and on the fly. And then the second period, we see it sort of evening out. Now we've got the hang of it, and we're in a win-win situation. Next slide. So, challenges. You know, we listen to our school nurses and our school staff tell us time and time again, connecting with families is so difficult for them. Phone numbers are out of service, or they change, or we have a transient population in one community or another, and we can't get a hold of folks. And school-based health centers traditionally don't have that challenge. It's a challenge, but it's not that high of a challenge. Well, COVID hit, telehealth came into play, and it became a gigantic challenge for us to connect with families. Our parent organizations were giving our providers phones that were linked to the parent organization. So you get a parent would get a phone call from a hospital, from a nonprofit healthcare agency, and have no idea who it was. So our phone numbers were getting blocked, or practitioners were calling from the home base, from their parent organizations, and guardians just weren't answering. So it took some time to connect. Then we threw at students and guardians a new platform. They're already trying to figure out Moodle or Google Docs or this platform and that platform with school. And now we're throwing at them, hey, try out Zoom. And it was just, it was a huge challenge. Students didn't have a steady schedule initially. So we had what we've never had before, which was a high no-show rate. And we saw a huge decline in referrals from school staff. School staff were trying to figure out where students were and what was happening. Next slide. With our challenges came great success once we overcame them. And after the initial hiccups of telehealth, we had limited breaks in coverage. And so we were able to close the gap. We saw that guardians were able to connect better with our providers, both medical and behavioral health providers, and that they were part of the planning process, part of the treatment process. Initially, when a mental health provider specifically meets with a student and family and takes them on as a case, they do an intake. And so you get the basics and the backstory for every student that you see. And then you may not have any encounters with that parent for a few weeks until you do a check-in, or for 30 days until you reevaluate the treatment plan. But telehealth has allowed families to be part of the therapeutic process. And then with our medical staff, it also allowed our medical staff to connect right in the moment with families. So a student would come down, once we got back into school, they would come down with a sniffle or a sore throat, and they'd be sent right to the isolation room and then home. But we were able to call that parent, schedule a telehealth appointment, do an assessment, support them in finding or figuring out where a COVID test was. And so telehealth didn't just support our mental health practitioners, but also our medical practitioners. Next slide, please. So we had a bunch of telehealth bills come through the state in this legislative session. four significant bills were these four that you see on your screen. And I'm going to go through and sort of pick them apart for you and let you know where they stand. And school-based health centers had participation in the development and advocacy of all of these bills. And then you'll see it sort of come to fruition at the end. You can go ahead to the next slide. So our first bill was House Bill 5450, an act concerning telehealth, just a telehealth bill. This bill was supposed to add dental hygienists to telehealth. It was supposed to avail insurance coverage for those folks who were temporarily living out of the state, which was a large portion of our students at some point in time were going back and forth between states or getting stuck out of state. And so this bill would have helped cover that. It also wanted us to, Connecticut, to join the Psychology of Inter-Jurisdictional Compact. And what that is an interstate agreement that's designed to facilitate telepsychology, and temporary in-person, face-to-face practices from state to state. This bill would also allow us to amend telehealth statuses as it pertains to mental health care providers. It was raised and it died in committee. And you see why, because it's included in SB2, and I'll get to that. You can go ahead to the next slide. The second bill was Senate Bill 375, and that's an act concerning telehealth as well. The only purpose of this bill would have been to extend telehealth provisions to June 30th of 2024. At the time, we had provisions until June 30th of 2023. It was raised and it died again. Next slide. The third bill is Senate Bill 1. This is an act concerning childhood mental and physical health services in schools. This was a huge bill in the state. Initially, telehealth services language was included in this bill. It was later removed. School-based health centers, the association itself, was highly instrumental in writing this policy. And it's probably the biggest school-based health center bill I've ever seen in my 25-year career. It is the Disneyland of school-based mental health bills. And it would allow $10 million of expansion funds to school-based health centers in Connecticut. So what they did is remove the telehealth language. They made it a mental health bill only, and it was raised, and fortunately, it was passed. And it's sitting with the governor, who is going to sign it within the next, hopefully, week or so. And we'll expand our budget line item for the next 2 years by $10 million. You can go to the next slide. So Senate Bill 2. This is not the Disneyland of school-based health center bills, but the Disneyland of telehealth bills for Connecticut. And if you go to the next slide, I'm going to pick it apart for you. So you can see what it covers. And that's just, what I could pick out that was really important for this. We'd be here all day talking about this bill. But this is what was really important and to Connecticut telehealth providers and practitioners. You can go to the next slide and I'm going to pick it apart for you. So we call it SB2 to shorten it up. So SB2 allows certain out-of-state providers to participate in telehealth services until the end of the fiscal year 2024. And it permanently authorizes certain out-of-state mental health, behavioral health providers to practice in Connecticut. This was super important because we saw in a huge increase, like every other state, in mental health needs for our school-age children. But we saw a lack of mental health providers. Either they were dropping out of the field they were going into private practice, or they were home, they weren't practicing, or the need is just too great for us to be able to fill. So being able to pull staff or providers from other states to practice in our state through telehealth was huge. Next slide, please. The second thing that this that SB2 did was to extend reimbursement to the end of the fiscal year 2024. Again, telehealth services were going to end June 30th of 2023, and so was a reimbursement. And so this would extend delivery of telehealth services and the reimbursement for telehealth services until June 30th of 2024. And there were other little minor changes that it asked for, but that's the most important part of that provision. Next slide. So this bill also allows for insurance coverage for, sorry, I just saw the note that we're running out of time. All right, so the important part of this is that it clarifies that telehealth excludes audio-only telephone for those policies that use a provider network, and it applies coverage requirements to high deductible plans. So as we see an increase of privately insured or commercially insured school-based health center students, that's important because they have high deductible plans. It also, you can go to the next slide. It also ensures that insurance policies cover telehealth services in the same way that they would cover face-to-face provider services. Next slide. And lastly, it allows the Office of Health Strategies to determine through data collection a couple of things. If raising the reimbursement rate for telehealth is really worth it for the state, what's behind it? You know, we always have to have data. So, so is there a need? What's the usage? Are telehealth services effective? And so the Office of Health Strategies will now be tasked with doing a study of telehealth services in Connecticut, and we're looking forward to the next legislative year. Thank you. And I apologize for having to talk so fast.
Thank you, Melanie and Andrea. It is just a lot of information. So I'm going to ask our other speakers to come back here. We are going to take a couple more questions. We're not going to be able to answer all the questions in Q&A, but we will download those and try to get them answered after the webinar. So the quick questions for you, Melanie. Were any of the bills passed in Connecticut yet, or are they still going through the legislative process?
Yes, so Senate Bill 1 and 2 were big wins for us. So school-based health centers are going to see $10 million and telehealth pass. So that's great.
Okay, great. We have a question from an anonymous person. Is the issue of not being the primary care provider come into play for school-based health centers, Fqhcs?
Yeah, that's a great question. For what typically happens with school-based health centers, as the student's non-primary care provider, what we try to work really hard with, it's part of our national quality initiative, is that there is a really, if in the best circumstances, it should not be a problem. So we never want a school-based health center to be replacing a primary care provider if a student already has a primary care provider. We want them to be partnering with the primary care providers. So we work hard to have school-based health centers have consent so that they are talking to each other and able to share particularly when an annual well care visit is happening at the primary care provider site, so that those records can be shared with the school-based health center, and then care from the school-based health center can be shared back with the primary care providers. We work real hard at trying to have that communication happen, and for local PCPs to know that we're there to enhance and collaborate and not to replace. So that is the ideal.
From Lisa Stothko, who in the school assists with facilitating the student to provider visits? In our local schools, we have one nurse per 3 schools, which adds a challenge for a facilitator.
So I can speak for probably most of the school-based health centers across the state or across the country. In the middle school and high school, that's not usually an issue because the PASS system, they call into the classrooms, they're old enough to walk unattended or unescorted. And then at the elementary school level, the school-based health centers staff often do that. They go and they find the child and they escort them to and from.
From Alex Hamza, where does Ohio stand on out-of-state providers, and are there special exceptions for this project? I think he's referring to the Switzerland project. If so, what are the enrollment requirements / contact?
So for our out-of-state provider rule, I can put it in the chat. It's a separate rule. I don't think we had it in our slides, but we do enroll out-of-state providers. If we have like bordering states, that's in our policy. We'll enroll, a lot of patients go to Indiana or West Virginia or Kentucky. So we do enroll those out-of-state providers. In other cases for out-of-state providers, we'll enroll them if there's like an emergency or some sort of like prior approval for us to cover services out of state. So I'll put that the link to that rule in the chat so you can see all the requirements for an out-of-state provider.
Okay, and we're going to take one last question. My apologies, we're not able to get to all of your questions here. This has been a great webinar. Obviously, a lot of interest in it. It's from Teresa Gonzalez, and it is either for Christie or if the Ohio ladies would like to answer it. Does your behavioral health services include sexual orientation and gender identity services?
We don't have like specific procedure codes for those. Like there are diagnosis codes like gender dysphoria and things like that. So that would be, so I guess the services aren't really focused on that condition. It's really, if it's an evaluation and management service and you're talking about gender identity or things like that, you might put a different diagnosis on the claim, but we don't have like specific services that are geared towards that specifically. It would really be kind of like the diagnosis code and what happens at the visit.
All right. Well, I want to thank our fabulous speakers again. Let me just pull up the slides one last time here. So a little bit of information to wrap up our webinar here. Again, thank you to Christie Guinn, Nichole Small, Meredith Schram, Andrea Shore, and Melanie Wild-Lane for this wonderful webinar today. You guys were all fabulous, as proven by like the great attendance and also the amount of questions that we had. Please know that today's webinar was being recorded. Both the recording of the webinar and the PowerPoints will be made available a few days after this webinar on the CCHP website. You will also get an evaluation form after this webinar. Please fill that out. That really helps us with deciding what future webinars to do and also helps us with the funders who help sponsor these webinars as well. Our next webinar for next week is on licensure. So this is the lineup of speakers that we have for that. So the registration link is up on our website if you would like to go ahead and register for that webinar. Again, remember to fill out your evaluation form. We want to thank everyone for attending today. Thank you once again to our great speakers. Have a wonderful day. Have a wonderful weekend. Bye-bye.